So the audience, welcome. It's a privilege being here and reporting you about, if you ask me, a really successful case of NTRK fusion inhibition. A short introduction of myself. My name is Philipp Ivanyi. I'm a medical oncologist here from the very north of Germany, which is still beautiful. And I'm here responsible as an adjunct professor for medical oncology in head and neck, GU and sarcoma. And so let's go more or less directly to the case, which is more interesting than my person is. My conflicts of interest is always mentioned towards all topics. So the story starts once I was really, let's say, a little bit younger than I'm today, with a 56-year-old veterinarian physician, basically. And at that time, I was really a young assistant physician, not really well experienced in oncology. And this was, of course, first meeting. As you can see, this patient did have really a severe hand-foot syndrome, and she suffered a lot. In particular, on this picture, it's not so clearly, but during the main courses, she suffered in particular hand-foot syndrome, higher grade most of the time, at least 3 on the fingers of the left hand, only the digit finger and the thumb, which is quite uncommon patient. And I always wondered how comes, and I asked her, well, how come that you have by majority hand-foot syndrome on this hand? And she said, well, I'm a veterinarian. And I said, okay, I got it, but still, it's not reasonable for me having the hand-foot syndrome on this particular fingers. And she said, well, I'm a veterinarian on a pig farm, which is my pig farm, and there I have to do manual activity. I said, okay, but still, why on only the 2 fingers? And the solution was really funny for me. She was castrating pigs, and this means she was tearing, and as you're not familiar, TKI side effects, mechanical stress, in particular on only 2 fingers, was the reason why she suffered from this exclusive hand-foot syndrome. So, and here's the solution. The patient has had thyroid gland cancer, and as you're familiar, this is also a domain of tyrosine kinase inhibition therapy. So we're coming now to the story of the patient, the whole story from the beginning. She has had T1N1, B1, M1, so a synchronized metastasized disease, which primarily in 2009 has been operated aggressively, and of course subsequently followed by radioiodine therapy. And again, the metastases have been metastasized. As those diseases are continuing and progressing slowly, also this case did, she received during the years from 2011 to 2013, again, radioiodine therapy as well as metastectomy and radiotherapy, and also due to bowel metastasis, she got a therapy with denosumab. Sooner or later, all local therapy and radioiodine therapies are not feasible anymore, and you're ending up with those patients which slowly progresses with a tyrosine kinase inhibitor. In that time, sorafenib was standard of care. You're all familiar with sorafenib, a multi-tyrosine kinase inhibitor with a particular recognizable toxic profile, and one of the major problems with this substance is also this patient suffered from hand-foot syndrome and diarrhea, and ultimately, as you can see, we could treat her on a longer period. We were forced to decrease the dosage down to 200 milligrams a day. Otherwise, toxicity was really not appropriate for a palliative care setting. After progression, we changed at that time also standard of care to lenvatinib in second line, also a quite toxic multi-tyrosine kinase inhibition drug, which does have a little bit decent tox profile, but again, hand-foot syndrome as diarrhea and also hypertension, which is most of the time easy to handle, was the result of lenvatinib adverse events, and also sometimes dizziness. And also here again, over time, we were forced to decrease the dosage down to a level of 10 milligrams per day. Sooner or later, at least she profited a long time, nearly approximately 3 years from the drug treatment. She ended up with a progression again, and we at that time no other trials have been possible or other drugs in Germany. We did a re-challenge with the multi-tyrosine kinase inhibitor sorafenib, and the toxicity was the same, and so the exposure was only 200 milligrams. So, and then at December 2018, the patient suffered really from a highly symptomatic progression. During the whole time, the eco performance status also deteriorated, and at that time here at the end of 2018, he was already at a performance score of 3. So at that time, in January 2019, I depicted here the pictures. This was the cervical area where you see the tumor as well, and it's easy to believe this lung picture that this is a highly symptomatic patient, with lymphangiosis. Also, she coughed a lot of blood and was short of breath. Now, then at that time, really the question is what to do. I give you some suggestions, and you might rethink to this period of time what could have been done. You could do a sorafenib treatment beyond progression concept, which is not really great, right? You could do a re-challenge with lenvatinib. You could try to find a trial which we did not succeed, or we could do some really off-label, which is not so easy to go in Germany, or you simply place, which also would be to some extent appropriate on best supportive care. So basically, we were really out of any options. But then all of a sudden, since I was on a congress in ESMO in 2018, that's why I place here a banner from the ESMO, I remembered something I saw on ESMO. And actually, I never thought that advertisement in medicine might be of relevance. I followed a story which was advertised by this fish here with the tentacle, and because I was always interested, what is this octopus for, right? And that's why I ended up in the story of NTRK. I missed the paper in New England Journal, so I was really not aware. So what to do? We have now this veterinarian colleague with really highly symptomatic progression, and we were basically end of option. And I thought, hey, well, maybe we should go to NTRK inhibition. So is it really trustworthy to believe in NTRK? This period was really for me a new experience, and I get to the literature. And as we are familiar, we have some fusion genes, and we are still discovering in thyroid cancer something. We have the RETs family, we have the TRK family, which is also years ago already reported, but we haven't had good drugs about this topic. We have the IX story as well. We also have BRAF, and we have also the PPARG story. So there are alterations for sure reported in literature. If you look currently to literature, in particular in papillary thyroid cancer, there are reports of NTRK fusions up to 25% of the cases. So it's really basically worse to look in thyroid cancer for NTRK alteration. So what to do? I simply called my pathologist of confidence and said, hey, can we measure NTRK? Can we get a reasonable result if we address this topic? And lucky-wise, my dear colleague was already familiar with the story and established several techniques which still have been under investigation. So the patient went simply with this worse out of option situation to the screening. And what we did in the beginning, we did an immunohistochemistry staining for TRK ABC with a pan-TRK antibody. And this was a result which was positive due to the judgment of the pathologist. And we went to an NGS, and we all of a sudden found really in our first case where I indicated an examination, lucky punch, we indicated really a TRK fusion. So from this, I give you a short report how we do it today. We modified a lot of strategies in our general clinical procedure, and we also evaluated this, and believe it or not, we really find the ordinary incidence of NTRK fusions, which you are familiar with, is quite low, but it's worth to find. This is the way we're doing it currently in clinics. In all cancers who are believed to be high-frequency NTRK tumors, those tumors are really going upfront very rapidly to an NGS oncomine assay to see whether or not, with the most highest sensitive evaluation method, to see or not whether or not NTRK is around. And then the rest strategy depends on, and this is defined with the pathologist, on the clinics and also the histology. We have disease, for example, the NSCLC, so lung cancer, where upfront molecular testing is state of the art. And we expanded this panel, of course, through also NTRK testing. And this means also those cancer patient specimens directly go to Oncomine. And then, of course, we have those diseases which are not really known to have an oncodriver, or which is not really justifiable also in terms of the financing by health insurances to do upfront an NGS. But all of the patients, we mostly try to get them at least in an immunohistochemistry staining strategy with TRK ABC. And then since our pan-TRK antibody is a little bit weak according to NTRK3 fusions, if we don't have here any signal, we do again a FISH exclusively for NTRK3. So, and if disease which is not upfront tested with NGS, and the disease which is not known to have a high frequency of NTRK, and the patient at least get this kind of screening, and once he's there negative, we really consider him also as an NTRK negative tumor, where we are not going deeper to further analysis due to ultimately also unlucky-wise financial restrictions. So, but if we have here a positive signal, of course, all the specimen is going directly to NGS to getting confirmation of the result. And this is let's say, German real-time screening assay for all specimens the pathologist received, which works quite well, and which also is from the financial toxicity, where you're not always getting the NGS refunded, a quite appropriate strategy. So, and ultimately, so my personal conclusion is, he who seeks finds, right? And we found in this patient the alteration. So, of course, we, after having the results, get the patient on an TRK inhibition. This time it was with larotrectinib. So what comes out of it? We started, as I mentioned, in December 2018 with preparation and screening, and in January 2019 we could start with treatment here with larotrectinib. I depicted here in red the body weight, in purple the tumor marker, in green the hemoglobin value, and again in another purple the ECOG performance state, and in gray the ALT as a surrogate marker for potential hepatotoxic events. As you can see, after starting with larotrectinib already, the weight increases. And, the oncologist is not a physician who is really sad about once a patient gains weight. The tumor marker rapidly decreased. The hemoglobin value stayed on a little bit level above 10, and the ECOG performance status decreased. So basically, the performance status improved. And as you can see already in a very short time here from January to April, we already reached local CR and overall a very good partial remission, which is quite fast after seeing this impressive progressing pictures. According to toxicity, you can consider body weight gain in this kind of therapy, if you look to the approval trials, also as an adverse event, since NTRK is also believed to have some regulation function with the eating habits. But nonetheless, in the trial, it was considered as an adverse event, but this was not really something the patient suffered from. I simply interpreted it not as a drug-related adverse event. I simply interpreted it as a success of a potent oncology therapy where the patient could restart to have fun while eating, still on therapy. We have here a small period from March to May of CTC1 AE hepatotoxicity, which was not really a problem if you are familiar in general with tyrosine kinase inhibitor. And as you can see, the hemoglobin value also reported adverse event in the trial. It was okay, and we did not transfuse the patient with a hemoglobin value always above 10. And now you can say, hey, Dr. Ivanyi is also reporting about a story, and it's only, miracle. No, let's go to the picture that you start to believe me. I showed you already those patient pictures here from CT scans, lymphangiosis, pleural infusion, tumor formation on the cervical area. This really looks not good. And after 3 months, you can see already changed modality MRI scans. Sorry about that. But you can see the alteration here decreased the avidity according to contrast enhancement substances decreases. Also, the lung picture improved. The lymphangiosis also decreased. And if we go on the time axis, according to RECIST criteria here, at least in 2019, this really fulfilled criteria for complete remission. And again, confirmed the complete remission again on 2019. So a rapid response, pressing response after seeing in particular this pulmonary picture, which continued here and documented to 2019. So how everything, and by the way, thanks to my radiologist for doing this nice preparation that was mentioned on below. How did the story continue? It continues like the following. You can see the body weight still increased a little bit, not causing any clinical complaints. And as I mentioned, I think he interpreted it as an improvement of general condition. We have had once again here little problems with liver toxicity, but if you look to the values, it's 13 units per liter. So this means only CTC1 toxicity, so minor toxicity without causing any problems. Hemoglobin also didn't cause any problems. And other toxicity I don't need to report because there haven't been any. But ultimately, every successful story most of the time in life ends, as you can see here, in June 2020, but this is still a quite impressive result. The tumor marker increased and also the patient starts really to deteriorate then fast. We consider this as really a resistance towards NTRK inhibition after nearly 2.5 years of very good quality of life. And ultimately, this progression was again very rapid and tried to place the patient on a trial for NTRK resistant NTRK fusion tumors, which failed unlucky-wise because we haven't here some trials in the area. And ultimately, the patient died. But keep in mind, 2.5 years later than the beginning, and this means 2.5 years before, we already have been, due to conventional strategies, out of any sensible option. So then I'm coming to my conclusion, dear colleagues, and my conclusion is simply, he who seeks finds. So believe it, NTRK fusion tumor really exists. They are rare, but it's worth searching for them because if you find a patient, if you get access and get the patient on the drug, NTRK inhibition, it's really highly potent, it's highly effective drug, and it's really safe. And therefore, the most funny thing, the patient was really lucky because, she still needs to work on her farm and still was castrating pigs, and she never complained about this hand-foot syndrome anymore. And so ultimately it was also related to good quality of life, at least to the patient. So the audience, thank you very much for your attention. If you have any questions, don't hesitate to contact me by email. And then I wish you all the best and keep safe, even though the pandemic is still running.